We conduct the study because we could perceive that Clopidogrel is remaining one key treatment in acute coronary syndromes. And given that Clopidogrel is a prodrug that needs to be absorbed and transformed, and the absorption and hepatic transformation are regulated by genes. These genes have different genetic variants that may influence the level of Clopidogrel in blood and may influence the platelet reactivity and ultimately the ischemic events. For this reason, it would be interesting to know the genetic profile of Clopidogrel metabolism of each individual patient before giving the drug to the patient. So basically, to respond to your question, why we performed, because we were searching for improving the quality of selection of antiplatelet drugs to give to the patients. The study design was quite simple. Patients with acute coronary syndromes were randomized to receive dual antiplatelet therapy based on clinical data only, which was the standard of care, or clinical data plus the genetic polymorphism of 3 genes, ABCB1, 2C19*2, and 2C19*17. And patients then were followed up for the occurrence of cardiovascular death, myocardial infarction, stroke, or BARC-defined 3 to 5 major bleedings. And that was basically the algorithm of the study design. The result is very important because it turned out that those who were randomized in the pharmacogenetic arm, they have a lower risk of cardiovascular death, myocardial infarction, stroke, and BARC-defined bleeding. So there was a 40% relative risk reduction in the risk of having these unwanted events during 1 year of follow-up. And this could be seen as a clinically meaningful result. Unfortunately, the study was interrupted prematurely, and therefore we could not enroll all the population, but only 25% of the population. And therefore, we cannot exclude that this result could be due to play of chance. I believe that with this trial, we got 2 results. First, we demonstrate that it is feasible to genotype acute patients with acute coronary syndrome in different institutions, and therefore this is the first result. The second one is that this field is very promising if you want to improve the quality of the selection of dual antiplatelet therapy in your patient. If you have the clinical data, you can reach a more personalized, a more individualized treatment by knowing the results of the ABCB1, 2C19*2, and 2C19*17 genes variants.